Alrighty. Good afternoon or good morning if you're joining us from the Pacific region. We will get started in just a minute. We're just allowing people into the webinar room, and you all are only in listen-only mode, but you have access to our chat box and our Q&A pod in the Zoom in case you want to interact with us and the speakers today. So thank you, and we'll start very shortly. All right, so welcome you all. Thank you for joining today's webinar titled The Health of Asian American and Native Hawaiian Pacific Islander Patients Served at Health Centers, an analysis of the 2020 Uniform Data System, or UDS for short. This is an annual webinar hosted by AAPCHO and is funded by our Bureau of Primary Health Care grant, which again serves all health centers across the country, including the continental US, Hawaii, and the Pacific region. So we're glad to have you here today. And if you are able to introduce yourselves in the chat box, we'd love to see where people are joining us today. So, and I have lots of colleagues from our AAPCHO team joining us today as panelists and moderators. So I'm sure at this point in 2022, we are all comfortable with Zoom, but for those that are, again, maybe not familiar with the webinar features of the Zoom, we have very simple tools that we'll be engaging with and allows you all to engage with us as attendees. So the first is the chat box. You are able to see who's, again, in the room if you're interacting with us by chat. And we have two colleagues from AAPCHO who will be monitoring this chat box. We have Christine Alarcon, who is our manager of storytelling and communications. And we also have Gabrielle Penaranda, who is the program manager for training and technical assistance. So feel free to ping Christine or Gabrielle in case you have any issues, tech issues, content issues, and they'll be monitoring the chat box. And then for the Q&A, we definitely want you to utilize that feature in Zoom in case you want to ask questions that we can save for the end of this webinar. We have about an hour and 15 minutes allocated for today. So please do chat those in, and we'll be sure to address those towards the end. And if you really want to engage with us verbally, we also have the raise hand feature. So if for any reason you want to speak up rather than type your questions, we can unmute you manually from our end. And then lastly, for the survey at the end, it'll pop up after you log off of Zoom. It should be a brief survey just to let us know what you think, what you'd like to see in the future. So feel free to take that as soon as you log off after today's webinar. So that is the Zoom housekeeping. And aloha from a lot of our Hawaii partners and members. Thank you. So quickly, if you're joining us and not fully aware of who AAPCHO is, we are the Association for Asian Pacific Community Health Organization, and we were formed around 1987 to be a national voice to advocate for the unique and diverse health needs of Asian Americans, Native Hawaiians, Pacific Islanders, especially in the community health provider space. And you'll see here just our mission, spread, and impact. Again, advocacy, collaboration, and leadership are really three big focus areas for our staff, our members, our board, and partners across the country. And when I say country, that also includes Hawaii and the Pacific, or the USAPI. And so you'll see here that, again, a lot of our needs vary by region, and we are always in communication with many different government, community health, and cross-sector partners to ensure that we are aligning needs, especially with the pandemic and everything going on these days. And for today, I'll be your main moderator. I'm Albert Eisen Jr. I go by he, him, and I'm the Associate Director for Training and Technical Assistance. And then we should be joined by Adam Carbolito, who is our Director of Policy. He's actually on jury duty and might be popping in. In other words, if he doesn't we'll have backup plans for you all, so don't you worry. And then we also have Jen Lee, our Deputy Director. And then we lastly have Julia Liu, our Research Assistant. Since this is a UDS report analysis, just really want to give a shout out to Julia and the research team at AAPCHO for going through a very intensive analysis of the 2020 data. And we'll be going through the 2021 data analysis in the next year. So stay tuned for that as well. And just to level set with you all too, we'll be throwing out acronyms today, but in the report when it's published later this summer, you'll see a lot of acronyms related to, again, our communities, AA, of course, Asian American, and then AANHPI Serving House Centers translates to Asian American and Native Hawaiian Pacific Islander Serving House Centers. And then NH/PI is Native Hawaiian/Pacific Islander. And then we also distinguish the NHPI Serving House Centers as the Native Hawaiian Pacific Islander Serving House Centers, and then UDS. This is really centralized around UDS, which is the annual data collection for all house centers, around 1,400 of you who report to HRSA, or the Health Resources and Services Administration, every February. And so thank you all again for being partners in that work for HRSA. We know that this data is meaningful, but also limited, and that's why AAPCHO tries its best to analyze and bring in other sources of data to really give you a better environmental scan of what's happening with our A and HPI communities. And just to kind of give you a sense of where we're at with our populations across the country, we know that Asian Americans, Native Hawaiians, and Pacific Islanders are still the fastest growing racial and ethnic group, with over 25 million residents in the continental US, Hawaii, and the US territories as of 2020. And AAs and NHPIs represent still more than 50 racial and ethnic groups and over 100 languages spoken. And we know we don't talk about the different dialects within different cultures and countries. And so those numbers could be much higher in terms of language and language access. In terms of growth across the community, Asian Americans in the US grew about 31%, so from roughly 18 million to 24 million between 2010 and 2020. And for the Native Hawaiian and Pacific Islanders, we also saw a 24% growth, which translates from roughly 1.4 million to 1.7 million in that same time period of 2010 to 2020. And in terms of what's happening in the current environment, we wanted to call out and really acknowledge what's happening, especially with the COVID-19 pandemic starting in 2020 and really compromising services, operations, patient care, et cetera, in the House Center program and across our service providing space. There's been still changing landscapes with the demographics within ANHPIs. Again, some of those issues are influenced by the socioeconomic environment, geopolitical environment. And, when we unpack that, we can talk about migration drivers such as education, access to healthcare, access to employment, needing to be with family, and then climate change, which we have some sources in our report that will be published later. And I'm just calling out to, in terms of the different subgroups, for Asian Americans, the rise in anti-Asian hate, xenophobia, and just the really racist and discriminatory practices by the government and also by our, fellow citizens that are, really calling attention to different issues that Asian Americans are feeling really high anxiety and fear from. And then for Native Hawaiians, if you would just pick up the news, there's a lot of debate or sparked around indigenous sovereignty in Hawaii. And then for Pacific Islanders, like in the Marshall Islands, really the climate change and changing ecosystems have caused some changes in populations and migrations. And so our report will briefly highlight, some of those current issues, but the bulk of the report will really talk about kind of what the Health Center Program UDS data is telling us from that point of view. So just want to acknowledge that, the report doesn't have everything in it, but we want to acknowledge the different issues at hand. And this is just some screenshots for you if you Google some of these, and we'll have these links and sources in our report. You can look them up in terms of current and emerging issues for our AA and HPI community. So in terms of you all in the room today, we want to just get a sense of kind of where you are located geographically, but also your organization type. So if you don't mind entertaining us with these quick polls. You'll see all three of these polls launched on your ends, and I'll read them out loud for those of you. The first one is a pick list. Which of the following best describes your organization type? Again, our HRSA Bureau of Primary Healthcare program focuses on community health centers, but we are always open to inviting any entity, cross-sector partner that is working with the community health center in your local, state, region, or even, local city. And this next question is, if your organization has new and growing populations of Asian Americans and or Native Hawaiian Pacific Islanders, let us know your location by HRSA region. We know that HRSA and other federal entities tries to provide services like training and technical assistance on a more regional level, just to really have it be more tailored. So feel free to let us know which regions you represent, because we know that different populations have moved in the past few years, especially with the pandemic. And then the last question is, which Asian American and or Native Hawaiian subgroups does your organization serve? So feel free to be more specific in terms of specific ethnicities in the chat box. And I'll just leave this up for about 2 minutes here, and I'll call out some observations from the chat box as you all answer the poll questions. And I know I'm getting some marks that there are black boxes on your screen here, so excuse the Zoom glitches. So I'm seeing here, 44% are representing community health centers. So thank you all for joining. This is definitely focused on your data that you submit every February to HRSA. And then I see that we have some PCA and HECN partners. So those are our fellow training and technical assistance providers on a more state and regional level. Let's see. In terms of HRSA regions, we see Region 2 really highly represented. So that's New Jersey, New York, Puerto Rico, Virgin Islands, and then Region 6, Arkansas, Louisiana, New Mexico, Oklahoma, Texas. All righty. And then of course, our highest number, which is not surprising to me, Region 9, which is the West Coast, Arizona, California, Hawaii, Nevada, Guam, and our US territories. So thank you all for participating in this poll. And then I see here, choice for national orgs. Dr. Nia, you can feel free to just put national, the National Training Technical Assistance. We'll consider that. All righty. So I'll leave that up for now. And in the chat box, feel free to again, type in some of your thoughts to those poll questions. So for today, we'll have about 30 to 40 minutes of content. First, we'll start off with presenting an overview of patient demographics, health utilization, and patient health outcomes at AA, NHPI, and NHPI serving health centers. And in that, we'll also highlight key differences between AA, NHPI, and NHPI serving health centers and other community health centers across the nation based on that 2020 UDS analysis. And then lastly, we'll discuss some of those implications and key trends, findings, and opportunities to increase access to care and improve health outcomes for our ANHPI and NHPI serving health centers. So stay tuned, and please, again, if you have questions throughout this webinar, you can chat them in. And with that, here's our brief agenda, and we should be ending right on time, if not earlier. And I'm going to start us off with our spotlight on AAPCHO and NHPI serving health centers by our fabulous Julia Liu. So Julia, take it away.
Thank you, Albert. So before I get into the analysis portion, I'm going to be talking about some of the changes, limitations, and the methodology for it. So moving on to the changes to the UDS and the new analysis. So there has been some changes from last year. So first off, the quality of care measures are now aligned with the versions of Center for Medicare and Medicaid Services. So this is to reduce the burden of data reporting, just to make sure everything's aligned up with electronic health records. What was removed was the asthma measurement, which is the use of appropriate medications for asthma. And then what was replaced was the dental sealants. So now instead of that, they're looking at primary carriers prevention intervention. So it's to encompass the dental sealants. What was added, there was a few things. So depression remission at 12 months, any prescriptions for PrEP, HIV screening measures, any diabetes, eye and foot exams, as well as medical attention, breast cancer screenings, and if you didn't know, we're in a COVID-19 pandemic, so they also included COVID-19. For the analysis, we had the similar ones from last year, but we did include the analysis for COVID-19 and depression. I won't be speaking on that today, but it is in our report, so that is going to be fabulous to read. Moving on to the methodology. So for this, our data source, like Albert said, is the UDS. So each year, health centers, grantees, and lookalikes report on their performance using the measures as defined in the UDS. So the UDS is a national standardized reporting system that provides consistent information, including the health center patient population, characteristics, enabling services, staffing, and quality of care measures. So in 2020, there was a total of 1,375 health centers in the continental US, Hawaii, US territories, and the COFA nations that reported to UDS. I do want to make a note that there are some health measures that are significant to Asian Americans and Native Hawaiian Pacific Islanders that may not be referenced in UDS, but they are found in other data sources. So for the purposes of this report, AAPCHO has actually formulated a specific methodology to create a profile for the Asian American and Native Hawaiian Pacific Islander serving health centers, as well as the Native Hawaiian Pacific Islander serving health centers. So these are the definitions that we have came up with. So first off, the AANHPI health serving health centers. So they serve the highest number of Asian Americans and Native Hawaiians Pacific Islander patients as reported in the 2020 UDS data set. So in other words, we grabbed the top 10% of all the health centers in the UDS. For NHPI serving health centers, these are health centers that serve greater or equal to 1,000 Native Hawaiian Pacific Islander patients that reported in the 2020 UDS. So based on these definitions, AAPCHO was able to identify and analyze a total of 138 AA NHPI serving health centers and 38 NHPI serving health centers from the 2020 UDS dataset. I do want to also make a note that AAPCHO worked with community stakeholders to refine our definition. So it wasn't just a sole job from AAPCHO, we worked with community members. And so if you would like more information about this, we have it in the report of the rationale, the background of these definitions. We also looked at the averages and we calculated that through the raw data from UDS, and to determine any statistical significance, two sample t-tests were conducted and we looked at the significance level of 0.05. So before I do want to get to the analysis, I do want to speak on the data limitations as well. So with the data limitations, I just want to recognize that before pretty much upfront to provide any context for analysis. So first off, the UDS dataset provides summary health center profiles, including population characteristics, like I mentioned before in the last slide. However, it does not contain any patient level data. So we could not do any direct comparisons or cross tabulations between Asian American and Native Hawaiian Pacific Islander populations, as well as other racial and ethnic groups for the majority of the UDS dataset. So we use the health center's averages based on the largest proportions of the Asian American and Native Hawaiian Pacific Islander populations as a basis for our comparisons. Also, I do want to note that the UDS aggregates the level data and it potentially pretty much masks the differences and hides disparities between the subgroups found in other studies. So for example, several studies had demonstrated subgroups such as Filipinos and South Asians have higher rates of diabetes compared to other Asian American subgroups and white persons. So with aggregating the Asian Americans into one, the health disparities within the racial group are hidden. In addition, with our current definitions of AA, NHPI, and NHPI population groupings, it may unintentionally exclude smaller health centers that actually serve a large proportion of these patients from the analysis. Since the total number of patients are lower at a smaller health center, these health centers would not be included based on our definitions. Even with these limitations though, the UDS serves as the only data source for standardized information that's collected by health centers nationally. So even with the limitations, AAPCHO formulated a methodology to highlight groups of Asian American, Native Hawaiian, Pacific Islander populations, and AAPCHO continues to utilize the specific methodology to create a profile of the Asian American, Native Hawaiian, Pacific Islander serving health centers and the Native Hawaiian, Pacific Islander serving health centers to better understand the health status of the populations as well as the people that they serve in their communities. With improvements in the UDS data structure and better understanding of these health centers, AAPCHO is always committed to refining its definitions to equitably represent Asian Americans and Native Hawaiian Pacific Islanders in future iterations of this report. So moving on to our next slide. So this table here provides a breakdown of the total number of AA and HPI serving and NHPI serving health centers and their locations. As you can see on the very bottom, this is the total. These are the numbers that I reported before, but this is the breakdown within the continental US, Hawaii, US territories, and the COFA nations. And also shows as well the different countries that are in there as well. So moving on to the next slide, as you can tell that we are very diverse where all the health centers are at. So besides the continental US, the NHPI serving health centers are also geographically diverse and dispersed throughout Hawaii and the Pacific. So with this, the Pacific regions include the two US territories of American Samoa and Guam, as well as the Commonwealth of the Northern Mariana Islands, and the three freely associated states of Palau, Marshall Islands, and the federally states of Micronesia. So moving on to the next slide. So in 2020, like I stated before, there was 1,375 health centers, and they served a total of almost 29 million patients. 5.1% of the total were Asian Americans and Native Hawaiian Pacific Islander patients, and 1.03% of the total were Native Hawaiian Pacific Islander patients in the health center program. So with the 138 AA and HPI serving health centers, they served pretty much almost a total of 8.2 million patients, among which 13.5% were Asian American and Native Hawaiian Pacific Islander patients. So in total, AA and HPI serving health centers served 71.3% of all Asian Americans and Native Hawaiian Pacific Islander patients. With the 38 NHPI serving health centers, they served a total of roughly almost 2.6 million patients, among which 7.1% were Native Hawaiian and Pacific Islander patients, and thus NHPI serving health centers served about 61.6% of all NHPI patients. So in summary, you can see that our target analysis groups represent a majority of Asian Americans and Native Hawaiian Pacific Islander patients compared to the total population. So now we get to go to the fun part, into the analysis. So this graph here compares the national with the AA, NHPI, and NHPI serving health centers. And health centers naturally serve a high proportion of patients with one or more social risk factors. So in this graph, the blue, green, dark teal, however you see it, represents the national health centers average. The dark yellow is the AA and NHPI serving health centers, and the orange, red, brown is the NHPI serving health centers. So compared to the health centers nationally, both AA and NHPI serving and NHPI serving health centers report a higher proportion of patients with limited English proficiency. And then, oh, I believe we accidentally clicked on the next slide. We go back one more. Okay, perfect. So again, AA and HPI serving and NHPI serving health centers report a higher proportion of patients with limited English proficiency, which you can see on the very left side, so 33 and 30% versus the 24. The incomes below 200%, the federal poverty line, 92 and 93% versus the 91%, and Medicaid at 55 and 59% versus the 46, as well as public insurance at 64 and 67% versus the 58. AA and HPI serving and NHPI serving health centers both reported a lower rate of uninsured patients, about 20% and 18% versus the 22. And this may be attributed to the Medicaid expansion and insurance market enrollment efforts under the 2010 Affordable Care Act. So the lower rate of the uninsured patients may also be attributed to the higher rates of enabling services with the full-time employees that are employed at AA and HPI serving and NHPI serving health centers. Generally, health centers provide enabling services to reduce patient barriers to care, which includes interpretations, transportations, and much more. Many of these health centers also employ eligibility assistant workers as enabling service providers whose specific role is actually to enroll uninsured patients into public insurance programs. I do want to note that the UDS provides data on health insurance status for both the US territories and the COPA nations. However, it does not provide a reflection on the various health coverage and eligibility factors for the COPA nations based on their immigration status and their relationship to the US. So moving on to the next slide, this is going to be on uncontrolled diabetes and as well as uncontrolled hypertension. And so before I actually get into this graph, I do want to define these as well. So uncontrolled diabetes is going to be any hemoglobin A1C that's greater than 9%. And uncontrolled hypertension is any blood pressure that's above 140/90. So according to the 2020 UDS dataset, about 36% of adults were diagnosed with diabetes and 21% of adults had hypertension at the health centers nationally. So this table here shows the average health center patients with uncontrolled diabetes and hypertension by race and ethnicity. So according to our analysis, about 40% of the Native Hawaiian patients, which you can see again here in the evergreen dark green, and then the 43% of Pacific Islander patients, which is here denoted by the darker orange and red, have uncontrolled diabetes, whereas 45% of Native Hawaiian patients and 46% of Pacific Islander patients have uncontrolled hypertension. So comparing across all races and ethnicities, Pacific Islander patients have the highest rates of uncontrolled diabetes, and Native Hawaiian patients have the second highest rates, which is paralleled with the American Indian and Alaska Native patients. When it comes to uncontrolled hypertension, Native Hawaiian patients have the third highest rates, and Pacific Islander patients have the second highest rates. So compared to other racial and ethnic groups, Black and African American patients have the highest rates, and then the American Indian, Alaska Native have the fourth highest rate. So the high rates of chronic diseases in Native Hawaiian Pacific Islander patients could be attributed to sociodemographic factors, disparities, structural discrimination, and pre-existing conditions. So this actually provides an opportunity for health centers to develop chronic disease management programs that are culturally responsive to each racial and ethnic group. So for example, the Pacific Islander Diabetes Prevention Program, which is also known as the IDPP, serves as a model to build the infrastructure of local organizations to deliver Pacific Islander tailored and CDC recognized lifestyle change programs to these communities. The lower rate of uncontrolled diabetes among Asian Americans patients compared to the white patients may be attributed to potentially high rates of misdiagnosis, since Asian Americans are actually at a higher risk for type 2 diabetes at a lower body mass index than the standard screening guidelines. Additionally, the lower uncontrolled diabetes rates could be attributed to aggregating Asian American patients as one racial ethnic group. Like I mentioned before, the several studies had demonstrated the subgroups of Filipinos and South Asians having higher rates of diabetes compared to other Asian American subgroups and white persons. So again, by aggregating Asian Americans into just one racial group, the disparities are hidden. Moving on to the next slide, this is going to be regarding hepatitis B as well as tuberculosis. So on the left side, you're going to see this is hepatitis B, and then the right side is going to be tuberculosis. So when it comes to hepatitis B, Asian Americans make about 6% of the total population in the US, but account for 58% of the people who are living with chronic hepatitis B. So this figure displays the average rates of the hepatitis B per 100,000 persons from the UDS dataset. NHPI and NHPI serving health centers serve a higher rate of hepatitis B patients than the national average, which you can see here at 3.4 and 2.1 versus 1.7 cases per 100,000 persons. According to our analysis, NHPI health servings here is in the yellow, and then the NHPI servings is represented in the dark orange red. And then the national, again, is going to be represented in the evergreen or dark green. When it comes to TB, so Asian American populations are impacted at a greater rate and accounted for 35.8% of people who are living with TB nationally. And NHPI serving health centers have a higher TB rate compared to a national and NHPI as well. So this is at 5.0 cases per 100,000 versus the 3.0 cases per 100,000. So moving on to the next slide, we're going to be talking about the enabling services that I mentioned before. So AA and HPI serving and NHPI serving health centers demonstrate higher rates of certain quality of care measures, which include childhood immunization, cervical cancer screening, and controlled hypertension than health centers nationally. And we believe that these results may be attributed to the higher rates of enabling services staff, which are associated with higher quality health outcomes. So this table here represents the service staff ratios compared to the health centers nationally. In the middle, you're going to see A NHPI serving health centers, and on the right side, you're going to see NHPI serving health centers. So with the AA NHPI serving and NHPI serving health centers, they have more full-time equivalent enabling services staff. So for example, AA NHPI serving and NHPI serving health centers have 2.5 and 1.5 times more interpretation staff, which is the second to the bottom, compared to the health centers nationally. And another example is that AA NHPI serving and NHPI serving health centers have 3.2 and 3.4 times more patient and community education specialists compared to the health centers nationally. So moving on to the next slide, we are going to get into more of the quality of care when it comes to comparison of the health centers nationally. So AA and HPI serving health centers also demonstrate higher rates of breast cancer screening, cervical cancer screening, and tobacco cessation. However, I do want to focus on colorectal cancer screening primarily because they are the second most common cause of cancer for Asian Americans and the most common cause of cancer death among them as well. So in terms of colorectal cancer screening, AA and HPI serving health centers demonstrate similar rates of colorectal cancer screenings with the national average at 40%, which is going to be in the middle of the graph. As you can see here, they are very the same, 40% and 40%. However, there are still challenges that remain for all Asian American populations to get screened and tested, and it could be due to language barriers, inadequate communication with the providers, and this is regardless of their insurance status, and also stigma. There's a big fear, embarrassment that plays a role in this as well. So although enabling services support in improving health outcomes and health center quality outcomes in 2020, it did not meet the Healthy People 2020 goals, except for two, which was controlled hypertension rates and tobacco cessation. So as Healthy People 2030 is unveiled, there is an opportunity to establish new benchmarks and innovative care to improve health outcomes for Asian Americans and Native Hawaiian Pacific Islander patients and address other contributing factors to these health disparities. So that concludes the part of the analysis. I'll be moving on to passing this off to my colleague, Adam, for summary and recommendations.
So our director of policy is on his way home from jury duty, but we did record his part. So you all are going to hear recording. So let's just stand by real quickly.
Include that AA and HPI serve. Thank you, Albert. As Jules outlined and the report highlights, Asian Americans, Native Hawaiians, and Pacific Islanders face disproportionate health disparities and health access challenges, and community health centers are vital to addressing and providing care. The 2020 UDS dataset, like the 2019 UDS dataset, reveals similarities and differences between AA and HPI serving health centers, NHPI serving health centers, and health centers nationally in the United States and the US affiliated Pacific Islands. Key observations include that AA and HPI serving and NHPI serving health centers serve a higher proportion of patients with limited English proficiency, low income, and patients who rely on Medicaid and other forms of public insurance compared to health centers nationally. AA and NHPI patients demonstrate chronic disease disparities, such as diabetes and hypertension, compared to other racial and ethnic groups. AA and NHPI serving and NHPI serving health centers demonstrate higher rates of hepatitis B and TB compared to health centers nationally. And finally, that AA and NHPI serving health centers demonstrate higher quality of care in areas of childhood immunizations, cervical cancer screenings, and controlled hypertension. Higher quality of care results are in part attributable to the health center's higher full-time equivalent rates of enabling services staff. However, despite the unique and disproportionate disparities that AA and NHPIs and other communities of color face, there are significant gaps that should be filled to improve these communities. Firstly, AAPCHO recommends that health centers increase collection of social risk data and report disaggregated data for patients' race, ethnicity, and preferred language. In the healthcare setting, collection of and access to comprehensive, standardized, and disaggregated demographic data is essential for healthcare professionals, policymakers, and others to be able to identify, monitor, and develop targeted strategies to address and mitigate health disparities. This is especially important for AA and NHPI communities that represent more than 50 ethnic groups and speak more than 100 different languages, each with their own complex histories and experiences. And as we've pointed out, segments of AA and NHPI communities experience health differently and face differing health disparities that are masked when broad Asian or Native Hawaiian and Pacific Islander categories are reflected. Additionally, highly variable income levels, employment rates, healthcare outcomes, disease prevalence are all invisible in aggregated data. The lack of disaggregated data perpetuates existing disparities and does not allow nuanced solutions targeted to where they are needed most. And I also want to recognize that the Biden administration has indicated that data disaggregation and data equity is an important priority of the administration's broader equity goals. Especially as HRSA transitions to UDS Plus in the coming years, we hope we will include patient-level race and ethnicity level data. We believe that health centers can be a model for other programs across government. AAPCHO's second recommendation is for health centers to tailor health and social services that reflect the needs of AA and NHPI patients. As the UDS report demonstrates, AA and NHPI patients have a diverse array of health and social needs that require healthcare providers to tailor programs that account for cultural and linguistic patient needs. As we've seen throughout the COVID-19 pandemic and through numerous examples long before, a one-size-fits-all approach is insufficient to providing the care that patients need and deserve. We recommend that health centers invest in programs and care delivery models geared towards our specific patient populations and are specifically tailored to specific AA and NHPI communities. Additionally, we recommend that health centers invest in and hire, train, and sustain both AA and NHPI non-clinical healthcare workers, as well as AA and NHPI clinical professionals to ensure that patients receive in-language, culturally relevant support and critical navigation services that have been shown to increase health center visits and patient satisfaction. Patients should receive these support and treatment at all stages of the patient experience, from outreach and intake to discharge and follow-up. We recommend that health centers offer workforce skills-based training on the principles and concepts of cultural humility to help staff and providers navigate multicultural communities more effectively. And I will also highlight that language barriers pose an important and significant challenge for our community members. We are fortunate that AA, NHPI, and NHPI serving health centers are able to provide care and help patients navigate the healthcare system in language their patients can understand. But adequate language access services are not always available. The COVID-19 pandemic has really shed light to how dangerous and widespread this challenge is. It is imperative that individuals are communicated with in a language they can understand, and there needs to be more availability of qualified interpreters, multilingual staff, and translated materials at every stage of the patient experience. Lastly, AAPCHO recommends that health centers cultivate and sustain community and national partnerships. Health centers may not be able to provide comprehensive in-house services that address all social needs among vulnerable AA and NHPI populations, but through partnerships with local service agencies, faith-based organizations, and/or community-based organizations, a full coordination of care and community support can help improve outcomes for AA and NHPI patients. Additionally, health centers should leverage partnerships at various levels, including state, regional, and national networks, both within the healthcare setting and across various sectors. By leveraging these cross-sector and multi-level partnerships, health centers can strengthen existing programs and policies that may result in increased funding and resources to address health disparities for AA and NHPI patients living throughout the United States and the US API jurisdictions. To close this recommendation section, community health centers have played a pivotal role in providing quality, reliable, and compassionate care to all patients since their inception. And the reliance on health centers has not only as a critical part of the nation's social safety net, but as trusted leaders in their communities will continue to grow. It is essential that health centers continue to meet the mandate of caring all who seek care regardless of their ability to pay. And AAPCHO hopes and recommends that part of fulfilling that mandate is continuing to grow programs and services that meet the unique needs of the diverse populations that health centers serve, especially for Asian Americans, Native Hawaiians, and the Pacific Islander communities. I'll now turn it over to Jen Lee to provide additional resources and tools.
Thanks so much, Adam. I hope those recommendations resonate for you all. And I know many of you have contributed to our sort of brain trust and work here. And we hope that this kind of provides a pathway for all of us to advocate. So important right now for our communities to collect that disaggregated data. And I know to ensure we have a workforce that reflects the values and needs of our communities. There's so much work to do ahead, but I hope this provides some guidance. Additionally, I think AAPCHO has some programming and tools we just wanted to uplift related to today's presentation that if you haven't heard of already. This publication that's coming out, actually we have last year's publication referenced here. We do this annual analysis of the UDS data. We're always looking for new trends and eager, as my colleague said, to look towards UDS Plus for even more descriptive information about how our populations are experiencing access to care in the health center program. This year's publication, go to the next slide, is coming soon. We're still in final review. It's with HRSA, and it should be made available later this summer. So you will be on the top list to receive this as soon as we have that clearance. As participants today, we have all your contact information. So as soon as we have that clearance, you'll receive an email with the full report, and hopefully we can continue the conversation. The next slide, we just wanted to uplift, noting the recommendation to really collect social needs data. If your health center hasn't already begun this journey, I know many of you have, UDS is shifting and we're seeing good changes there, and we can expect to see more with UDS Plus on the horizon, but we just wanted to uplift a couple sections. I know maybe many of you health centers have this manual close by or downloaded on your computers, but in Appendix D, where you look at health center health information technology, there are a couple questions there. Question 12A, that really looks at food insecurity, housing insecurity, financial strain, and transportation and access to public transportation. So they're asking, how many, these are optional questions right now, but we'll see this develop and evolve over the next couple of years. But, beginning to ask, or if you have the data to show how many patients are screened for these focal areas. And then the second question there, 12B, if you're not using a standardized assessment right now, please indicate why or where you're at. So, I don't think many of you are new to that conversation, but it is a nudge and encouragement to begin, or we're certainly here to help you help find your way through to collecting this critical data for our communities if you aren't already. Another great resource, which you may have heard of, is the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experience, or PREPARE for short. It is a national effort for health centers and other providers to collect data needed to better understand and act on their patients' social drivers of health. This is a great resource. We have a link here. It's a tremendous team that's been working on this for many years, providing just orientation to this, how to begin to collect this data. There's about 10 chapters in this resource, everything spanning from data collection preparation to assessment and responding. There's a wonderful community of folks involved in this conversation and very active in contributing to just how health centers need to prepare themselves to be a part of the ecosystem, work with community-based organizations to meet these patients' needs. The Prepare assessment tool, we're happy to say, is translated into Arabic, Burmese, Chinese, Korean, Tagalog, and Vietnamese as well. So trying to make that as accessible as possible, and I'm sure it doesn't stop there. So please check out prepare.org for more information. And then the Enabling Services Data Collection Toolkit is an amazing companion tool. It works, enabling services for those of you who are non-health center folks, they're non-clinical services that aim to increase access to healthcare and improve health outcomes. These are things like transportation, interpretation services, case management, eligibility assistance and navigation, health education, outreach, and more. So these are, for our communities, the lifeline to experiencing care. It's not just the clinician visit, but all the folks they encounter to support them and succeed in their health outcomes. There's very little data about the impact of these enabling services on quality improvement and health outcomes among medically underserved populations. So this toolkit is really to help get you started in collecting that and connecting the dots around your narrative. What's the experience of your population through some of this data? We know many of you provide these services, and having that data to correlate is really going to make a difference in terms of where things are headed and how you can adequately get reimbursement for these services. So please check out that. This toolkit has everything from a needs assessment, readiness assessment, to sample workflows to collect this data, electronic health record integration, creating a database, and then report cards, things that are meaningful for your staff to show progress and support their buy-in and motivation to do this work. We know that's not easy. Lastly, I just wanted to, but not least at all, wanted to just uplift this amazing resource, the Pacific Islander Center of Primary Care Excellence. They were founded in 2017 by Pacific Islander health leaders and advocates to really design a plan and vision to improve the health of Pacific Islanders living in the United States, Hawaii, the U.S. territories, and freely associated states. As Julia shared earlier, our communities are vast, and our geographies are vast, and so there can be no shortage of support services that are tailored to address those unique needs. So PACOPSI is, PACOPSI for short, is the health equity partner within AAPCHO to meet these needs and provide that tailored technical assistance from our organization. So please check out the website that's provided there. And wanted to also just thank Dr. Mia Itoto, I think, who is on the line, who also has helped us advise on this report to ensure it's robust and representative. Our community umbrella is, our diaspora is wide and vast. So I'm sure, as you have all seen, just the hard work we do to try to uplift and expand the available data we have to work with to tell our stories. So that is it. And I will maybe hand it back to Albert, and we'll open up for questions. I hope you have plenty. Thanks.
Thank you so much, Jen. I think Adam hopped on for Q&A. So thank you, Adam, and also Jules. So we are going to have the last, 12 minutes, or if we need to stay on, we will stay on for more questions. So feel free to put it in the chat box. I know we have some, I believe Christine has given me some. Okay. So I'm going to actually punt this one to Jules around the data. Is there a breakdown of the numbers of deaths for Native Hawaiian Pacific Islander from colorectal cancer? And are there numbers available by age?
Yeah, that's a really good question. So UDS actually does not provide the number of deaths. When it comes to colorectal cancer, they primarily focus on screening, and when it comes to age, if they did have it, it's going to be focused on patients aged 50 to 74 because it's the primary average age of people who usually does get the screenings.
Great. And I guess related to that, we can check back with Dr. Nia Itoto. She mentioned that there were some cancer registry reports from the US API, and so we can share that as a potential resource if it's publicly available. So we'll get back to you with some additional resources on, again, NHPI based on the data that we were able to analyze outside of UDS in our follow-up email. In terms of others, I see that we have some folks commenting that it's really hard to prepare S2H data due to language and education. Most patients cannot fill it out themselves, and we don't have enough people power to assist with each person who needs to fill out a prepare or S2H screening, especially for those who are elderly. So just want to acknowledge that, yes, there are a lot of challenges to collecting social needs data, even though it's our top recommendation. We encourage folks to start small And if you have staff that are really skilled at working with multiple patients at a time, I know that there is some education for patients that are new to social needs screening. And so we've learned that when patients do it once, it becomes easier over time. And so perhaps it might start with a 30-minute visit, going over a social needs screening tool like Prepare. We know that Prepare is not the only one out there. But if they come back for their annual visit or for their checkups and whatnot, those kind of time studies show that patients fill those out really rather quickly, on average 5 to 7 minutes during a visit. And so it's really that learning curve for patients and for staff. And so if you need more assistance, as Jen mentioned, please feel free to reach out to us, training@apcho.org, and we're happy to kind of coach you through different workflows. There is no wrong or right approach to doing social needs screening. The goal is to kind of really align it with your existing data collection tools. We know that patients are really inundated, whether by paper or electronically, to fill out their intake and registration forms. And so sometimes in the Prepare trainings, we like to talk about crosswalking your data that you're collecting by paper and or your EHR from a patient's perspective. That way, you know what data might be already collected. And it's a matter of just, checking off which ones aren't answered. And I'll mention those UDS questions that Jen talked about: food, housing, transportation. Those are really what I feel like a lot of the policymakers and funders are focused on. But if you know other social needs and social drivers that you and your patients have really experiences with, we want to make sure that you can prioritize that in your workflows. So hope that helps. Let's see, other questions, Christine and Gabby.
No other question.
Great. Well, we want to definitely give you all time to think through. As Jen mentioned, we are undergoing HRSA review with our report, and just want to give a quick shout out again to Dr. Nia, Andrew, and other folks who were our community reviewers. What we didn't talk about too is we featured some health centers across the country, one Asian American focus, one Native Hawaiian focus, and one Pacific Islander focus narrative. So we didn't want to reveal that today. We wanted to give you kind of just a teaser for today. The report is about 40 pages long, so it'll be good summer reading when that's published. And then Christine, anything in the chat box that we want to acknowledge?
Nope. Thanks, everyone.
Yeah, thank you. We are pretty much closing out this bureau project year for AAPCHO. And so we are going to be restarting a bunch of activities starting in July and August. And so stay tuned. If you're not already subscribed to our AAPCHO listserv, that is the one-stop shop, our Frontline Digest, which Christine and our communications team leads effortlessly. And so we'll be kicking off some social determinants of health learning collaboratives in August. So if you have staff who are really on the front lines of doing social needs screening, that is one training opportunity that you could have them join. Again, that'll begin around early August, and we're just starting to plan that this month and in July. And we have some webinars coming up in next month's July calendar too. So if you haven't, Christine, maybe you can put in our website for subscribing to our newsletter. Great. Well, we'll stay on for the next 6 minutes if you have any questions. And if you don't, thank you so much for joining us today. June is almost over, and hope you all have great plans this summer, staycations or getaways, whatever you're able to do. Summer is a good time to really get outdoors. So stay cool, and thank you again for joining us for today's webinar.